Hello everyone, my name is Ruimin, and today I would like to talk about dynamic physician-patient matching in the healthcare system. This work is a joint work with Mutong Chen and my advisor, Dr. Hui Yang. So first, why we want to study this problem. Long waiting time for patients in the healthcare system in the United States has been a problem for a very long time. Report shows that the average waiting time from a patient to first make appointment and to first see the doctor is around 24.1 days in 2017. And this number has increased by 30% since 2014. And of course, this number is keep increasing. So there are three main causes for the long waiting. The first one could be the doctor is very famous, so the doctor is overutilized. Or on the other hand, if the doctor is very far away from the big cities, he or she might be underutilized. And the third case, the patient might go to a wrong doctor and then the doctor is misutilized. In this case, the patient needs to go back home and schedule appointment again. So those causes might cause poor patient experience and low physician satisfaction. So what people are trying to do these days is they either create call center to make patient call them and they find the correct physician for you, or they are trying to create recommendation system online after patient put in their system, put in their information to the system, they give you a list of the available physician. But here we want to say that patient-physician matching is a two-way street, which means that we not only need to consider patient's requirements, but we need to consider whether the physician can or cannot treat the patient and whether the physician is available or not. And other than that, specifically for the healthcare matching problem, there might be constraints introduced by the insurance type that the patient is getting. For example, there are two major popular type of the insurance plans that patients usually get. One is HMO and one is PPO. And together they may take around 70% of the market. The HMO plan is a little bit cheaper than the PPO. So whenever patient needs to go to a specialist, the patient needs to go through PCP first and then get referral. On the other hand, PPO is a little bit more expensive, so patient has more flexibility to choose whatever they want. They can either go for PCP or they can go for a specialist directly. So under such condition, our question becomes how we can match physicians and patients in such a dynamic environment under the insurance constraints. So in this study, we want to leverage the matching theory. The matching theory started with those economists who want to study how they can match a group of men and a group of women for a stable marriage problem. So in each group, man or woman, they have their own preference. For example, man number one, he likes woman number one best, and then goes woman number three and woman number four, woman number two. So each person in the group, they have different preference. So they're trying to study how to match them and create an optimized solution to make everyone happy at the end. So of course, there are different models for different matching problem. There are one-to-one matching, many-to-one matching, and many-to-many matching based on agent's capacity. So in this case, we want to leverage the classic deferred acceptance algorithm, DA algorithm, and extend that for our case because we assume that one physician can only see one patient at a time. So our objective of the studies are twofold. The one is we want to develop a physician-patient matching framework. And the second one is we want to observe the demand-supply ratio, which suggests the best mechanism for different scenarios. What I mean by different scenarios is, for example, we might have flu season. And in those seasons, we have way more patients than other normal times. So different algorithms might have different performance. So under different cases, different algorithm might perform differently. So which one is the best is also a problem we want to study. So as I mentioned before, one of the important things for a matching framework is how we set up the preference list from two groups. So assume that we have M number of patients and N number of physicians in our system. So the preference list for patients contains three parts. The first part is indicating whether patient and physician, they can or cannot be matched. And also the physician is specialized in patient's problem or not. It can be either one or empty. And the second one is an indicator, binary indicator, saying that whether the patient and the physician are in the same network or not. And if they're in the same network, which is 1, and if they're not in the same network, we put 0 on there. Means it's less likely, but they still can be matched because the patient need to pay extra for the out-of-network physician. And the third part is related to patient itself. It contains the rating of the doctors, and also they want to minimize the distance between them and the physician. They want someone close to them. And on the other hand, for physician, they don't care about whether the patient is within their network or not. They just want to make sure that they can treat the patient well. And also they want to see what, they want some patients that don't usually cancel their appointment. And also to be on time all the time. And this is how we update the classic DA algorithm. We name that as discrete DA algorithm. So basically, we are trying to make the time discrete and run the DA algorithm multiple times. So for example, we might run that every half a day or every 1 day to make sure that during every single period that our solution is optimized. So after updating the extend the DA to DDA algorithm, we start to think about how about if during the dynamic process, if 2 patients, they can switch their options and they can obtain an even better result. So we started to think about how about we feedback the waiting time for all the patients waiting in the queue each time after we run the algorithm. So here we add one more term related to the waiting time to the patient's preference list to make the cases that patient can switch with each other to obtain a better solution. And for the physician, we don't change the preference list. And this is where we extend and update the DDA algorithm. So here is within each iteration, we want to keep updating the waiting time for the patient in the queue. So in this case, they can always try to minimize their waiting time in the system. So this one shows the result of our simulation study. Our simulation study has 500 number of patients and then over 60 days with 20 number of physicians. And the average length of stay of the patient follows a normal distribution. And we also assume that each physician works 8 hours per day. So on the result part, we output 2 indicators. One is average waiting time on the left side, and one is the matching regret on the right side. So both of them are the lower the better. And for the blue line shows the DDA, or the algorithm we updated, and also the red one is the FDDA, the one we updated, we extend on the top of DDA. And also for the third line, which is shown in green, is the continuous DA, which is we want to run, we run the DA algorithm each time right after each patient's arrival, which is the current practice. We want to see how our algorithm performs compared to the current practice. And those 2 arrows showing that different DSR ratios, which scenarios is going to be better under different cases. And I'm going to talk about that more in the next slides. So far, this is what we have proposed. We proposed a novel matching system for personalized physician-patient matching in a dynamic environment with the consideration of the insurance constraints. And also, we first extend the classic DA algorithm to a DDA and further for FDDA. And at the end, we observed that when the DSR, demand-supply ratio, is less than 1.25, CDA is good. And then when it's between 1.25 and 4, and FDDA works the best. And when it's greater than 4, we want to choose DDA. And for the next step, because in reality, the HMO and the PPO, the customer, they can change the plan whenever they want. So we want to include this in our study. And those are the references that we have for our study. And then at the end, I would like to thank NSF Child Center for supporting this work. And at the end, I would also like to thank you for reviewing.